I would like to give you a rough overview, as this is really the introduction of our introductory series. I would like to give you a rough overview on how nutrition impacts our health. And I will focus on individual health, so nutrition and chronic disease, non-communicable diseases, but I will as well touch on a couple of other global health threats that nutrition is linked with. So the talk will have two parts. First one, as I said, nutrition NCDs, and I will mainly follow the three leading questions. How important is diet really? What does a healthy diet look like? And how fast do healthy diets work? I didn't learn anything about that in medical school. And from what I know, this is still mainly the case. And I do think these, or answers to these three questions, are able to change the perspective on the position of nutrition in medicine. And the second part is about the other global health threats, namely pandemic risk, antimicrobial resistance. And at the end of my talk, I will kind of introduce the main topic of Pauline's talk when talking about climate crisis as a health crisis. So let's dive right in. How important is diet really? In order to establish that, I would like to get some common ground on how important non-communicable diseases are, or how impactful they are. We all do know the main non-communicable diseases, namely cardiovascular diseases, diabetes, chronic respiratory diseases, and cancer. And we do know that they are still the leading causes of death globally. So that has been true for decades now. If we look at the left, they are the leading causes of death globally. If we look at on the right side, because most attendees today are from global north countries, high income countries, we do see that this is especially true for high income countries. While we do not want to forget that NCDs are as well increasing in middle and low income countries, while creating a thing that's sometimes called the double burden of disease, because there are still a lot of other diseases like infectious diseases, and societies are hit at the same time by non-communicable diseases. NCDs are as well responsible for over 50% of the total disease burden. So we can express that in disability adjusted life years, DALYs here, which is a measure of this disease burden and expresses the number of years lost due to ill health, disability, or early death. So it's basically a combination of lost quality of life due to years lived in disease or disability, and lost years of life when compared to expected life years. And third, quite typical measurement to look at the impact of certain diseases on us as a society are, of course, costs. And we can state that NCDs cause definitely the most direct health costs, for sure, in the global north. So direct healthcare costs are the costs that are paid for medication, visiting the doctor in the practice, being taken care of in the hospital. So these costs are 60 to 80% of direct healthcare costs are caused by NCDs. And then we need to add, to get an idea of the real costs of these diseases, we need to add output losses. Output losses are the costs the losses societies have to deal with because people with these chronic diseases can't work anymore, or can't work like they used to. And these losses, we do see in that graphic, the output losses of caused by the main NCDs on a global level. And we do see that these numbers are only about to rise, with the speed even accelerating, so that we're talking about 45 trillion US dollars of output losses globally by 2030. So main cause of premature deaths, more than 50% of overall disease burden, and major cause for huge costs in healthcare around the world. And this is especially interesting because we all know that a lot of these diseases are preventable. So as the WHO states here, at least 80% of all heart disease, stroke and type 2 diabetes, and 40% of cancers could be prevented if we were able to eliminate the main risk factors. And I know at least this impact of NCDs is getting taught in medical schools, but if you have a few minutes later today or tomorrow, I would really encourage you to let that sink in, really, because this is massive. Like, if we would only achieve half of that, like prevent 40% of heart disease, or if we would do only a quarter, this would still transform healthcare and societies fundamentally in many, many ways. So in the first place, of course, this would still just mean less premature deaths, less suffering of patients and their families and friends. And at the same time, as we wouldn't need to spend so much money and capacities on these then prevented diseases, the healthcare sector, and with it thousands and thousands of health professionals and researchers, could, for example, focus on diseases that we don't know much about yet, on the many patients that are completely underserved or basically just ignored in our healthcare systems. And having worked in social pediatrics and neuropediatrics, that's definitely a field where I can tell that there are a lot of families completely underserved by our healthcare systems. We could, of course, as well decide as a society and as healthcare professionals to use these capacities to use, and that's what I wanted to say here with opportunity costs, because we would have these capacities freed up to tackle other huge global challenges, for example. So definitely no need to focus all these capacities on preventable diseases, right? And with NCDs, we know as well that the major, and here I'm coming to the second part of that quote, the major risk factors are tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. That's at least what WHO states in some statements. And now we're getting closer to the importance of certain risk factors, and they seem to include unhealthy diet, so the topic of today. To do so, to look at and prioritize these risk factors, there's one great tool, one great research project with thousands of scientists gathering data from more than 200 countries around the world, coordinated by Washington and Harvard University, which is called the Global Burden of Disease Study. And this is the page healthdata.org, where all the results of the Global Burden of Disease Study are open source published, and there are great data visualizations. This is just a great tool for anyone who is interested in health and public health and the health status of the world, of certain countries, certain societal groups, whatever. So I really would invite you to check out this website and see what there is about the basically three major questions that the Global Burden of Disease Project is investing since the 1990s, which is basically, put simply, what causes most premature deaths, which diseases do people suffer from, and what are the risk factors for these premature deaths and diseases. And one tool that I like especially are the country profiles. So if you go on the website, go on projects, and then click country profiles, and type in the country of your interest or your country, you get a great overview on these data on your country, on including the risk factors, which we will see on a global scale in a minute. So some of the work of the Global Burden of Disease Study is attributing premature deaths or as well reduced life quality, like DALYs, to a lot of different risk factors, many, many more, of course, than in this statement of the WHO we saw before. So we can now take a look at the main risk factors, for example, to pick one of the measures we discussed before, for premature deaths. So this is a global scale, it's females, it's data from 2019. And yeah, you can look it up, and or just believe me that the graph for men looks very similar. And what do we see? What are the, these are different risk factors causing premature deaths. And we do see the 4 ones mentioned in the quote before. We do see alcohol use, we do see low physical activity, we do see tobacco, and we do see dietary risks on number 2 even. And that's even without malnutrition, which is a risk factor on its own. So number 2, that seems to be quite important already. But if we look at the other risk factors in the top ranks, we do see high systolic blood pressure, high fasting plasma glucose, high body mass index, high LDL cholesterol, and excuse me, we all know that these risk factors are heavily interlinked and are all linked with diet as well. And that's exactly what the authors of this project or of this study comment on when they say, because of the strong interrelationships between these risks, the true driver of this cluster, and this is the cluster of the main risk factors for chronic disease, right, and premature death, the risk in so the true driver of this cluster is likely diet, the risk in BMI, or both. So that's basically the answer to our first question, and it says that diet is, and I invite you again to check the country profiles of at healthdata.org to check how these risk factors work in your countries. And I bet, or I do know that if it's middle or high income countries, they look very much like the graph we have in front of us. Next question, what does a healthy diet look like? So we can do that quite quickly because I think most of you have some good ideas around that. Lots and lots of resources to ask here. We just stick with the global burden of disease study because they did not only look at the risk factors we just saw, but they defined or gathered from their data single risk factors within that pattern of a poor diet, so to say. So this is, we saw dietary risks in general before, and now we see single dietary risks again causing or are linked to premature deaths. Now it's both sexes and again a global perspective. And what's on we see on number 1, high sodium, which is mainly a proxy for consumption of highly processed foods. Most of us consume the main share of sodium through highly processed foods and not because they, I don't know, have put salt on the meal at their table or put salt in the water for their pasta or whatever. Same goes for high trans fats here, I think on number 6. So trans fats, mainly processed, fried snacks and food. So the two of them might be very well summed up as processed foods. Let's take a look at the other ones in the top ranks. We see low whole grains, low legumes, low fruit, high red meat, low fiber, low nuts and seeds, low vegetables. And it's not really difficult to see a second pattern, which is plant-based. So according to these dietary risks, a healthy dietary pattern would be mainly unprocessed or minimally processed, and it would be really plant heavy. And we do see that, and that comes as no surprise, I guess, in the most international guidelines and recommendations. On the left side, we do see the Planetary Health Diet of the Lancet Commission, which is focused on providing the optimal nutrition for individual health and planetary health. So probably Pauline will touch on this in her talk, so I will leave that for now. And we see on the right side, even more appetizing, the Canadian Food Guide, as well, with lots of vegetables and fruits, whole grain foods, and in the right upper corner, so-called protein foods. And they recommend to choose more plant-based protein-rich foods. So very similar to the Lancet guide, you end up with around 10, bit more, bit less % of animal-sourced foods that are still healthy. Interesting because of relevance for the other crises that are linked to nutrition that we're going to talk about. Interesting that both guidelines mention that well-planned, even more plant-based or even plant-exclusive diets, like a vegetarian or vegan diet, do very likely come with the same health benefits. All right, so we established that pattern. And how fast do diets really work when treating disease? So this is, of course, a huge topic. We could do a whole course on this alone, but I just wanted to give you an idea, because when I was in medical school, healthy diet was something like, yeah, that has some vague effect in some vague amount of time. But there is a lot of research telling us what diet can do exactly in different diseases and in which time frame. And it depends, of course, always on the disease, on the patient, and so on. But just to give you a rough idea, I picked 3 studies or 3 results here. First one, quite interesting, is a comparison of 3 different interventions. This one in hypercholesterolemic patients. Thank you very much. And we do want these interventions to lower LDL cholesterol, of course, and we do see how these interventions perform by looking at the change of LDL from baseline in percentage. One intervention, that's the control intervention, is a control diet with low saturated fat. It's already lowering cholesterol a little bit. The 2 interventions of interest are a portfolio diet, which is a completely plant-based diet, with an emphasis on cholesterol-lowering foods like soy and fiber-rich foods, and the control diet plus 20 milligram of a statin, which is a classic medication to lower LDL. And this is not at all meant to say that nutrition is medicine, or that nutrition could be enough in patients with high LDL. We are super happy to have this medication. This is an initial kind of low dose. We could, of course, increase that dose and get LDL further down, which we need to do in a lot of patients. But this is just to give you an idea of how long that takes and how long and how big the impact might be. And we do see that with the portfolio diet, just with that cholesterol lowering diet, we get LDL down by about 30%, and within the same time as the statin hits. So that's within the first 2 to 4 weeks, even. Another study gathered a few hundred participants from a certain company with different health issues and respective lab parameters. They put them on a plant-based diet for 8 weeks, plus 30 minutes of physical activity per day. So this is not diet alone, but more lifestyle medicine, basically. But what's important for today is that whichever parameter you look at, systolic blood pressure, LDL again, triglycerides, glucose levels, on average, all these groups benefit from this intervention after just 8 weeks, and the worst groups benefit the most. So again, we're talking about a couple of weeks. And the last example is a study on patients with rheumatoid arthritis. And I do want to show that because it's nice to get certain lab parameters in the right direction. And that's, of course, we know that's important. And if we show that to patients, that's important as well. But what's of main interest for patients is, of course, their symptoms, right? And we do see in these patients were put on a whole food plant-exclusive diet, so vegan diet in the first few weeks, and then the next 11 months on a vegetarian whole foods diet. And you do see that a lot of typical symptoms with rheumatoid arthritis, like pain, morning stiffness, tender joints, swollen joints, they do improve again within the first few weeks, and then mainly stay stable. So to answer the 3 questions, again, very roughly, we could dive into that a lot deeper, but how important is diet really? As we've seen globally, very likely the true driver behind the main risk factors for NCDs and premature deaths. What does a healthy diet look like? Mainly whole foods, mainly plant-centered, a lot of different patterns we can envision around this these main rules, I'd say. And how fast do healthy diets work? For NCDs, again, always depending on individual patient and disease, status of disease, and so on. But you will see results quite likely in terms of lab results, or sometimes even within a few days, certainly very likely within a few weeks. And for symptoms, quite likely within a few weeks as well. So I would definitely, looking at these answers, I would definitely consider diet a tool that should be quite a quite central aspect in the toolbox of all medical professionals. Moving to the second part of my presentation, that's going to be quite some crisis talk, and we all do know that we are facing various simultaneous crises right now, and a lot of them are linked to health, to global health, and a lot of them are as well linked to our food system. And we do talk about these three crises in particular as they are linked to the dietary pattern that we have just established for individual health. And within that pattern, these health threats are mainly connected to the part around plant foods versus animal foods. Yeah, as I only have 10 minutes left, it will be about 2 to 3 slides each crisis, but there's way more on our website and in upcoming webinars. Pandemic risk. We all know, we all live in a global pandemic since around 2 years. So we are very well aware of that threat now. And it's COVID-19 is in some ways quite a good example, because 75% of newly emerging infectious diseases are zoonoses, and already 60% of infectious diseases in humans are spread from animals. So when we talk about pandemic risk, we do mainly talk about zoonotic pandemic risk. This graphic shows us the primary drivers of past zoonotic disease emergence. So these are all factors that play a role when zoonotic diseases emerge and spread. And as with so many other things in medicine and health, we see a lot of different factors. Looking at two of the main ones, we do see land use change and agricultural industry change. And agricultural industry change here refers mainly to livestock industry, because modern livestock industry, with its hundreds or even tens of thousands of genetically identical animals, with oftentimes a suboptimal health status, provides an optimal breeding ground for pathogens. And land use change, so why is land use change such a huge driver? So simply put, land use change is always connected to the destruction or destabilization of intact ecosystems. And pathogens that were embedded in these intact ecosystems are now basically forced to find new hosts, which they will eventually do, and they are, because we as humans have changed this land to use it in some way. We are being put closer to those pathogens at the same time. And land use change is as well very much connected to our food system, and like the agricultural industry changes here, mainly linked to the livestock industry. And that's because global land use looks like this. And the land use is a huge topic when talking about the sustainability of food systems, and will for sure play a role in Pauline's talk as well. So of all the Earth's surface, we can use roughly 70%, rest is glaciers, deserts, whatever, we can't use it. And of those 70%, we do already use 50% for agriculture. And we would not want to, we cannot extend that use for agriculture. We need more land untouched, basically, to save biodiversity, to create intact ecosystems that can store CO2 emission, that can store CO2. So we do, at best, we reduce this land used for agriculture. And we see that roughly 80% of that land used for agriculture is used for livestock, so mainly meat and dairy production, while these are only supplying 80% of our global calorie supply and 37% of our global protein supply. So there's a huge mismatch, and put in different words, a huge opportunity to free up land, and as we're at pandemic risk, reduce pandemic risk. And so this graphic by the UN Environment Programme, I think, is doing a great job when stating what factors are increasing zoonosis emergence. Illegal and poorly regulated wildlife trade, not a topic for us tonight. Climate change, we will hear about that in a couple of minutes. Deforestation and other land use changes, we just heard a little bit about that. I will talk about antimicrobial resistance as well in a second, and at the center of it, there's intensified agriculture and livestock production. Off to the next health threat, which is antimicrobial resistance. Antimicrobial resistance was once framed a slow motion tsunami by the former Director General of the WHO, Margaret Chan. And antimicrobial resistance basically means that bacteria which cause infections develop the ability to stop an antibiotic from working against them. So this means that the infections caused by them can't be treated successfully anymore. And there are, we had a high-level meeting on antimicrobial resistance in 2016 by the UN. We have regular publications of models and research that draws a very grim picture. Here, for example, one that states that if we fail to address this problem, we could be confronted with 10 million deaths by 2050 due to antibiotic resistance. And this is not only about people getting diseases, infectious diseases, and worst case dying from them, but this really has the potential to undermine modern medicine, right? Because we know that a lot of our interventions, like certain surgeries, chemotherapy, and so on, are only possible because we have working antibiotics that prevent people undergoing these interventions from getting deadly infections. And there are two parts of the problem. One is, in the last 30 years, there hasn't been any breakthrough in terms of finding new antibiotic drugs, and that is still the case. And the second part of this is, of course, that antimicrobial resistance is growing, and there are mainly two pathways for it. The main pathway, and that's what all medical students and health professionals know, still the main pathway around the world in creating antimicrobial resistances is human medicine, right? That's our doing and the patient's doing. We prescribe antibiotics where there might be not necessarily patients are taking them in the wrong way. And even if that's all perfect, there's still, even if we apply antibiotics where they are needed and do that in the correct way, there is a likelihood of antibiotic resistance emerging. So this is still the biggest pathway, but the second most important pathway is related to food again. And this is because 70% of the sheer amount of antibiotics sold around the world, this is for the US, but the number is actually true for the whole world. 70 to 80% of antibiotics are consumed by animals and not by humans. So there is another opportunity to mitigate that problem. Now, this is the last health threat, and I will not talk about its connection to nutrition because that's what Pauline will do in a couple of minutes magnificently. I will just lead into the topic by describing the climate crisis as a health crisis. And yeah, definitely the biggest health threat of our century, if not of all human history. Dr. Ghebreyesus, the Director General of the WHO, said that the Paris Agreement is potentially the strongest health agreement of this century. Why would he say that? Well, we definitely all witnessed the weather extremes, the floods, the wildfires, the droughts, that happened just in the last couple of months around the planet. And it's obvious, it's crystal clear that they impact the lives and the health of the people that are experiencing these extremes. And it's crystal clear that climate crisis is making it much more likely for these extremes to happen much more often. But other than these obvious impacts that are covered as well a lot by media, there are a lot of other potential impacts of climate change on human health. And based on that graphic, I will just pick out a few of them. So at the center of that problem, we do have rising sea levels, rising temperatures, and weather extremes. And now there are, for example, heat waves, which I don't really hear a lot from in media, for example, or in healthcare. And in a heat wave in 2003 in Germany alone, 70,000 people died, and it's approximately 20 to 30,000 more deaths are expected per year due to heat waves in Germany alone. Another topic not covered a lot is our vector-borne diseases and vectors moving, and with them the diseases moving to different parts of the world. So again, bit of a Eurocentric view here, as most attendees are from European countries. The Asian tiger mosquito potentially transmitting dengue, Zika, chikungunya, and the West Nile virus, and the Anopheles mosquito transmitting malaria are spreading in Southern Europe now. We already had the first locally acquired cases of Zika and dengue in France. Ticks with carrying tick-borne encephalitis or Lyme disease are spreading further north, and these vector-borne diseases are certainly impacting the day-to-day medicine in practices and hospitals once they are more common in northern countries as well. Respiratory diseases. We do have longer pollen flight seasons due to climate change and the immigration of new highly allergenic species, like species so allergenic that they are being tracked down and eliminated where possible, because they pose such a threat to people who are allergic to them. And then again, more obvious shortage of water and food supply, and Pauline will touch upon how climate change is impacting food and food supply. Water and food supply, rising sea levels, regions where it will just be too hot to live, will force people to move away from certain areas. This will create environmental refugees, forced migration, civil conflicts with all the grim consequences. And last but not least, climate change is having a huge impact on mental health. We do already see in a lot of people who are basically just aware of climate crisis and not necessarily hit by its consequences already, there's a term called solastalgia, which means hopelessness, powerlessness, existential fears of the future due to the climate crisis. Then, of course, we do have these natural disasters and the sharp rise in suicides and mental illness in these post-disaster areas. And of course, impacts of civil conflict and war on mental health are obvious again. So that was a very, crisis, bad news crisis talk, so to say. And I do want to close my talk with two more uplifting and motivating quotes. The first is from Eric Holthaus. He's a meteorologist and climate journalist from the US. And he said, "You are alive at just the right moment to change everything." And we did hear, last IPCC report just came out a couple of days or weeks ago. We do know that there is this narrow time frame in which we need to act to reduce the crisis that we've just talked about. And we as health professionals certainly have a special role and responsibility in this. That's at least my belief. A second quote is from Christian Barnau. He's a South African surgeon who performed the first heart transplantation in history in 1967. And he said, "I have saved the lives of 150 people from heart transplantations. If I had focused on preventive medicine earlier, I would have saved 150 million." So this might be a quite bold statement, but if we more freely connect preventive medicine to changing food choices, changing food environments, and with all these knock-on consequences on chronic disease, on climate crisis, on pandemic risk, on antimicrobial resistance, this might even be an understatement. So very happy to give back to Josie and looking much forward to the talk of Pauline Scheelbeck. Thank you very much.